Hello, I'm Dr. Norma Devault, discussing a few of the selected obstructive pulmonary conditions that do have nutritional implications. Adverse effects of lung disease on nutritional status include increased energy expenditure. That's from simply the increased work of breathing, chronic infection, and possibly medical treatments. There is also reduced intake accompanied by shortness of breath, fluid restriction, decreased oxygen saturation while eating, anorexia due to chronic disease, and gastrointestinal distress and possibly vomiting. Additional limitations such as difficulty preparing food and lack of financial resources, possibly impaired feeding skills, particularly for infants and children, and altered metabolism. These conditions require specific alterations to the recommendations that normally are given to healthy persons. Chronic obstructive pulmonary disease includes COPD, which also embodies chronic bronchitis and emphysema, and asthma and cystic fibrosis. First, a word about malnutrition. Malnutrition and pulmonary disease are interrelated. They each adversely affect the other. That is, malnutrition adversely impacts the progress and complications of pulmonary disease, and pulmonary disease contributes to malnutrition. Malnutrition adversely affects the lung structure, the elasticity of the tissue, and the ability of the person to control breathing. As lean body mass is decreased, so also is the respiratory muscle mass. It affects the strength of the lungs and the effectiveness of the lung immune defense mechanisms. Protein and iron deficiency associated with malnutrition is reflected in low hemoglobin levels, which diminishes the oxygen carrying capacity of the blood. Respiratory muscle function is further compromised by low levels of calcium, magnesium, phosphorus, and potassium. Hypoproteinemia also contributes to pulmonary edema. Without sufficient proteins and phospholipids to produce the appropriate surfactant levels, collapse of the alveoli greatly increases the work of breathing. Vitamin C is required to produce the collagen needed for the supportive connective tissue of the lungs. Even healthy people need plenty of water, glycoproteins, and electrolytes to produce the normal airway mucus, and this mucus is produced in abundance with pulmonary disease. Weight loss is a result of inadequate energy intake when eating is difficult to accomplish and requires more energy than the person has. Weight loss in persons with pulmonary disease is associated with a poor prognosis. The primary goals of nutritional care for COPD are to facilitate nutritional well-being, maintain an appropriate ratio of lean body mass to adipose tissue, and to correct any fluid imbalance and manage drug-nutrient interactions. Challenges to meeting these goals are related conditions which may interfere with food intake. These include abnormal production of sputum, vomiting, rapid breathing, bloody mucus from the respiratory tract, thoracic pain, nasal polyps, anemia, depression, and altered taste, which may be secondary to medications and mouth breathing. Peristalsis may be impaired secondary to lack of oxygen to the GI tract. If the patient with COPD is retaining fluids, anthropometric measures and biochemical indicators of nutritional stress and status need careful interpretation because the extra weight of the edema may mask an actual state of wasting of lean body mass, and lab values may be depressed by hemodilution. Excessive carbon dioxide in the blood may result in morning confusion and headache. This can interfere with the ability to prepare and eat meals. Other significant factors in the nutritional assessment are blood oxygen saturation, fatigue, anorexia, difficulty chewing and swallowing, constipation, and diarrhea. Depletion of nutrients is reflected in low body weight for height, reduced triceps fat fold measures, and decreased food intake. Pulmonary complications such as airflow obstruction, lowered gas diffusing capacity, retention of CO2, decreased respiratory and limb muscle strength, and altered muscle function. Those all create problems and challenges to the COPD patient. Cor pulmonale results in edema, which leads to fluid restriction. Watch for camouflage wasting of lean body mass. In the nutritional assessment of COPD patients, you'll want to pay particular attention to respiratory status and oxygen saturation. In the nutrition assessment, weight for height and all of the other indicators of risk for malnutrition are important. In the diet history, you'll want to determine what situation they have at home and that are related to meal planning and whether they eat alone or have someone to help prepare meals. Environmental factors also need to be assessed, including their physical abilities and financial resources to obtain the food that they need and potentially the need for assisted living. A number of recent studies have contributed to our understanding of COPD and nutrition. Excessive calories from carbohydrate may cause lipogenesis. This leads to an increase in CO2 production and a respiratory quotient above 1.0. If the COPD patient cannot respond to the increased CO2, respiratory failure may result. Although it may seem counterintuitive, diets with fat contents of 30 to 50% are shown to be helpful. The net effect is lower respiratory quotient and less CO2 production. Also remember that overfeeding causes respiratory distress. Other studies have shown that fruit and vitamin E are protective against death from COPD. Loss of abdominal fat improves airflow limitations. Fruits, whole grains, and moderate alcohol have independent beneficial effects on COPD. The American Dietetic Association's respiratory diet is a good starting point, but may need to be tailored to the particular situation. The general recommendation for undernourished pulmonary patients is a high-calorie, high-protein, and especially high-fat diet to promote gradual weight gain and ease the complications of breathing and of eating. Early in the day, there are usually fewer symptoms of disease that would interfere with appetite. Unless the patient has morning confusion and headache, this may be the best time to consume the larger meal of the day. Frequent small meals are recommended. They should be nutrient-dense and not exhausting to chew. The timing of fluid and medications needs to be tailored to the individual to promote an optimal eating pattern. Because the diaphragm is often low-lying due to hyperinflation of the lungs in COPD patients, there may be less room for the stomach. Also, overfeeding can cause complications. When the COPD patient is trying to eat while breathing through their mouth, he or she is prone to swallow air, and this adds to gastric distress. If they're simply too tired to eat, the consistency of the food may need to be altered to a smoother consistency. Supplements may be helpful if they're not consuming the quantity and variety of the food needed to supply their nutrients. Fluid requirements must be tailored to the medications, their clinical status, and other diseases that may be present. Fluid intake of 2 to 3 liters per day for stable patients with no edema, and water is an ancillary expectorant. Patients with cor pulmonale may require restricted fluid intake. Smokers must stop smoking. They need more vitamin C, fruits and vegetables for the antioxidants that are contained. The energy needed by pulmonary patients is substantially increased. The very act of breathing may require many times as much energy as a normal person requires to breathe. And this is not to say that their overall energy requirement is much higher, simply that their total energy for breathing is more labor intensive. Complications make adequate intake, digestion, absorption, and even excretion of nutrients difficult. To estimate the energy requirement, you can use the Harris-Benedict equation or indirect calorimetry. The usual body weight, rather than the actual body weight, may be more appropriate for the calculations if severe edema is present. Energy requirements may also be increased due to infections, fever, or malnourishment. An increase in the work of breathing may increase energy expenditure and contributes to weight loss in COPD. So start with 1.2 times the resting energy expenditure and monitor and adjust from there. Macronutrient requirements include primarily high fat and high protein. As dietitians, we need to be familiar with the patient's need for high fat because physicians usually do not order a high fat diet. Very often the patient will have concurrent diseases such as cardiovascular disease, renal disease, cancer, or diabetes, and they all affect the diet prescription. The energy and macronutrient requirements can be translated to a diet plan in much the same way as we usually do with exchange planning for diabetes. So you establish the levels of energy, fat, and protein, and carbohydrate. Translate that to a diet plan and then spread the intake across 6 small meals. As you can see in this example, the 6 eating times are not 3 large meals and 3 small snacks. Rather, they are 6 mini meals. In this example, I've used whole milk because of the fat content. The meal with the most chewing involved is first in the day. The 6 meals facilitates actually consuming the amount of nutrients and avoids the problem of overfeeding. To enhance appetite, promote oral intake, and lessen fatigue when eating, a few guidelines for modifying the diet are to use small portions of nutrient-dense foods and be sensitive to the interaction of medications and mealtimes. For instance, don't give the patient an expectorant and then ask them to eat. These patients very likely will need assistance with food shopping and preparing meals. If they use up all their energy getting the food ready, they may simply be too tired to actually eat it. Prepared meals may be beneficial. Also consider meals on wheels or other similar home service delivery. COPD patients often do not have energy for shopping and preparation and may need help with that. Enteral nutritional supplementation by mouth can help increase their total caloric and nutrient intake. Pulmacare or some similar product is often used in hospitals. Patients' nutritional status improves with supplementation, but it usually must be continued to retain the benefits. In other words, it may not increase their nutrient stores, but it does help them get through the day. Nighttime tube feedings can cause aspiration of food into the lungs, and oxygen consumption during sleep is lowered. COPD patients can help themselves in several ways. First and foremost, if they smoke, stop smoking. Avoid exposure to irritants in the workplace. Avoid air pollution, extremes of heat, cold, and altitudes. Drink enough fluid to keep the sputum loose so it can be brought up by coughing. Maintain good nutrition. For COPD patients, this again usually means a high-fat, high-protein diet taken in small feedings. Asthma is another condition with nutritional implications. Asthma is among the most common chronic conditions in the U.S., affecting nearly 15 million people. It causes 1.5 million trips to the emergency room every year, and about a third of those ER visits results in hospitalization, and more than 5,500 people die from asthma each year. The prevalence of this condition has been increasing over the past 20 years. It's important for people with asthma to know that eating a healthy diet can help you feel better and breathe better. Follow the dietary guidelines for Americans, whether the Food Guide Pyramid or the My Plate method. Asthmatic symptoms may be related to allergen exposure, including food allergies. One common sign of asthma, persistent mouth breathing, interferes with eating. Recent studies show that weight loss for obese patients with asthma reflects and reduces airway obstruction and decreases the variability in peak expiratory flow. Obese patients who lose weight benefit from improved pulmonary mechanics and better control of airway obstruction. Eating fresh, oily fish, such as salmon, herring, and tuna, may reduce the incidence of childhood asthma. So for both COPD and asthma, eating can be, as you see, hard work. Eat 6 smaller meals instead of 3 large ones. Realize that the diaphragm cannot work well when the stomach is full. Plan to eat meals before you're too tired or too hungry. Breathe evenly while chewing. Stop eating if you need to catch your breath. Relax at mealtime. You may want to use frozen meals or prepared meals or take out meals for a restaurant if you need to make life easier. But be aware of the label, the food label, because sugar, salt, and fat content may be higher than food that you prepare at home. Sit whenever you can in the kitchen, for instance, while you're chopping food or cutting or mixing food. And you may need to consider assisted living. Universal design houses may be essential. And also avoid foods that cause gas. There's a third obstructive pulmonary condition with nutritional implications, and that is cystic fibrosis. Nutritional care for CF is individualized due to the many complications of cystic fibrosis. First, a complete nutritional assessment is performed, and increased energy requirements are identified. Vitamin and mineral supplementation is often required to compensate for maldigestion and malabsorption of foods. Many CF patients experience maldigestion and malabsorption, so pancreatic enzymes are needed to help them digest and absorb foods. More than 90% of CF patients do take pancreatic enzymes to help with digestion of carbohydrate, protein, and fat, and to help with weight gain and promote nutrient absorption. These supplemental enzymes are enterically coated capsules that survive the stomach acid and release into the small intestine. They're taken before all meals and snacks, even breast milk, formula, or nutritional supplements. Only a few foods do not require or benefit from additional enzymes, and those would include juices, fruit, soft drinks, infant rehydrating formulas, tea, coffee without cream, hard candy, gum, and popsicles and the like. The majority of cystic fibrosis patients do have pancreatic insufficiency with maldigestion and malabsorption of food, especially fat, so it's important that they routinely take their supplemental enzymes. A registered dietitian will calculate energy needs based on a number of factors, including age, gender, basal metabolic rate, physical activity level, the presence or absence of infection, severity of their lung disease, and steatorrhea or fat malabsorption. In general, encourage extra energy intake rather than less physical activity. Protein requirements are based on grams of protein per kilogram of body weight, and it varies between 1.5 gram per kilogram for adults and 4 for infants. Fat recommendations for CF is 30 to 50% of total calories, or more as tolerated. Dietary fat helps provide energy, essential fatty acids, and helps absorb fat-soluble vitamins. Fat limits the volume of food to meet energy demands, and you need to test routinely for abnormal blood lipid profile because visible signs of EFA deficiency may not be present. Encourage EFA sources such as canola, flaxseed, and corn oil, and soybean. The remainder of calories beyond the protein and fat calculations will come from carbohydrate. Supplemental fat-soluble vitamins are needed up to 2 times the RDA. Sodium requirements may also increase up to 4 to 6 grams due to sweat losses in CF patients. Most children and adults consume adequate, even more salt than needed, but supplemental salt is required by infants and by children, and also by adults who have fever or during hot weather or physical exertion. Salt is added routinely to baby food for cystic fibrosis infants. At times, it may be necessary to add nocturnal feedings, especially when the CF patient is not gaining weight or growing normally even with the added calories. A number of considerations apply to tube feedings, including nutritional and medical status and various risk factors. In conclusion, as you've seen, the general nutritional recommendations for healthy people may not apply or may need to be altered to meet the needs of persons who have compromised pulmonary function. Appropriate nutritional support for these conditions can limit complications and improve the health and well-being of persons with obstructive pulmonary conditions.